In acute aortic insufficiency, the retrograde backflow of blood results in a quick rise in the left ventricular end-diastolic volume. Aortic regurgitation is the flow of blood back into the left ventricle from the aorta during diastole. Any condition that prevents the aortic valve from closing completely can cause this problem. Valve flaps fail to completely seal the aortic orifice during diastole and thus permit backflow of blood from the aorta into the left ventricle. When the valve does not close all the way, some blood comes back each time the heart beats. As a result, the chamber holds more blood. When a large amount of blood comes back, the heart must work harder to force out enough blood to meet the body's needs. The acute increase in preload and afterload does not allow the time for the left ventricle to adjust to the rapid increase in volume during diastole, and this also results in a sharp rise in left ventricular diastolic pressure. When the left ventricular diastolic pressure rises above the level of left atrial pressure, premature mitral valve closure and mitral regurgitation can be seen. Additionally, there will be increase in left atrial pressure and pulmonary capillary wedge pressure that cause pulmonary edema. Compensatory tachycardia may occur to stop the decline in stroke volume and hypertrophy with increased wall thickness. In chronic aortic insufficiency, the left ventricle compensates for the diastolic regurgitation of the blood from the aorta into the left ventricle by remodeling of the left ventricle via eccentric hypertrophy of the cardiomyocytes and left ventricular dilation to allow for an increase in left ventricular stroke volume and a lesser increase in wall thicknesses than that which would be seen in acute aortic insufficiency. In chronic aortic insufficiency, at first, the larger left ventricle helps maintain good blood flow with more force. The left ventricle of the heart widens and the heart beats very strongly. The left ventricle increases the force of contraction to maintain an adequate cardiac output. Over time, the heart becomes less able to supply enough blood to the body. In aortic regurgitation, blood from the aorta returns to the left ventricle during diastole in addition to the blood normally delivered by the left atrium. Because of the increased volume of blood, the left ventricles dilate trying to accommodate the increased volume of blood. It also hypertrophies, trying to increase muscle strength to expel more blood with the above normal force, raising systolic blood pressure. Now, the arteries attempt to compensate for the higher pressures by reflex vasodilation. The peripheral arterioles relax, reducing peripheral resistance and diastolic blood pressure. This could cause it to get larger and thicker, usually resulting in hypertrophy. However, the left end-diastolic volume and left ventricular pressure rise to a high degree such that the muscle fibers can become maximally stretched, left ventricular remodeling and compensation mechanisms fail. These changes can cause interstitial fibrosis and a drop in left ventricular compliance. The low aortic diastolic pressure results in decreased coronary artery perfusion. Eventually, the heart becomes weak. Patient may feel tired and short of breath.